So my favorite slide, as you all know, data. Without data, you're just another person with an opinion. And so what is the data to date? And so CHoSEN Quick collects some limited sociodemographic information, and I thought I would share that with you. In terms of maternal race, we see that nearly 2/3 of our mothers are white, 3.7% American Indian or Alaska Native, 3.3% Black, 0.8% is other, and then clearly we have a data issue because 26.6% is missing or unknown. In terms of ethnicity, we have nearly 1/4 of our mothers identifying as Hispanic, and then 2/3 non-Hispanic, and then 9.4% as missing or unknown. In terms of maternal insurance, we have nearly 90% of our mothers that are publicly insured. English is the primary language. However, for 37%, it's noted as missing or unknown. In terms of maternal OUD status, so I called it such because we are collecting information around maternal receipt of MAT as well as discharge disposition of the infant. And both of these speak to really the status of our mother's opioid use disorder treatment or lack thereof, or availability of supports in place. So such that about 50% of our mothers in our data set are receiving MAT and the other half are not. And in terms of discharge disposition, about 2/3 of our infants go home with the biologic parent, 28% went home with a guardian or a foster parent, and then 4.8% was unknown. And so if you can imagine what are the reasons that an infant may not be discharged to their biologic parent, it gets at the either insufficient resources for families and/or families still struggling with illicit substance use disorders and not in treatment programs. Shown here is our primary outcome, which is our average length of stay for opioid-exposed newborns. Here we have nearly 800 infants captured, and we've limited this analysis to infants that are greater than or equal to 35 weeks and whose length of stay was not affected by another diagnosis. We've seen significant declines in the length of stay from a mean of 13 days down to about 7 days. And I know that for individual hospitals, that decline has been even more significant from nearly a month down to 6 days. Shown here are the percent of OENs who received any pharm therapy, and that's declined from 50% down to less than 20%. And among those infants who required pharmacologic therapy, shown here is the reduction in their mean length of stay. That's declined from 20.4 days down to 13 days. Here we have infants, the percent of infants that are eligible to receive mother's own milk. And so we've developed guidelines around which mothers are eligible to breastfeed, and this number hasn't really changed much. So we are hovering around 50% of mothers with opioid use disorders are eligible to provide human milk. And then among those that are eligible, did their infants receive mother's own milk? And we haven't seen a lot of change, and we're hovering at about 80%. But keep in mind, this is a very high percentage of breastfeeding, even amongst the general population of healthy mothers without any substance use disorders. This just speaks to the fact that Colorado is very much a breastfeeding state, and even amongst mothers with opioid use disorders, this percentage is quite high. Now moving prenatally as well as into the postnatal period, we're going to look at some of our outcomes there. And here we have the percent of OENs or whose mothers received any sort of antenatal counseling about what to expect in infant care practices for this population. And while we've seen increases from 5% to 11 and maybe most recently 20% of mothers receiving counseling, you can see that this number is still far from optimal, and it's really still just a small fraction of our mothers that are receiving prenatal counseling. Shown here are the percent of OENs who received early intervention referral. And again, we've mentioned this many, many times that fetal opioid exposure in and of itself does not guarantee you EI services, but every infant should at least get a referral at the time of hospital discharge so that an evaluation can be made when the infant is gone home. And so this has increased significantly from a mean of 21% up to 47% most recently. Still, we have a lot of room to improve, but this dramatic 50% increase, or perhaps even more, has been really, really terrific. Here we have the percent of OENs who received handoff to a primary care pediatrician. And this is also where we struggle, where we haven't seen a lot of movement. And we continue at about 20% of our opioid-exposed newborns having a documented verbal handoff to their PCP. And remember, these are high-risk infants, and therefore this handoff is critical. I'm going to move on a bit to racial ethnic disparities. Now that our cohort size is large enough, we could start to look at these differences across maternal sociodemographic characteristics. And we've highlighted racial ethnic disparities to share with you. And so this is really looking at the comparison of Hispanic mothers versus non-Hispanic mothers. And so shown here is the average length of stay for infants born to Hispanic versus non-Hispanic. So on the upper graph, you can see that for Hispanic mothers, this process change or this decline in the length of stay happens at about January, March of 2019. Compare that to our non-Hispanic mothers, where this change happened much earlier in spring of 2018. Whereas we all end up in the same place in the first quarter of 2020, the fact that there is a lag for the Hispanic population is something that requires further attention. And so Blair Weichel, who has been responsible and done an awesome job with all these analyses, is doing a deeper dive to understand this ethnic disparity. Here we have the percent of OENs who received farm therapy. Again, the upper graph is the Hispanic population and the lower is the non-Hispanic. And again, we see this lag where for the non-Hispanic mothers, very soon after implementation, we see that there's been a dramatic decline in receipt of pharmacologic therapy, whereas for the Hispanic infants, it's taken a much longer time and we're not seeing changes until spring of 2019. Here we have the average length of stay born among infants who received farm therapy. And again, the upper graph shows Hispanic mothers, and this lag continues compared to our non-Hispanic mothers, where very quickly we see this significant change. And so we'll be doing a deeper dive into this. In addition, we could look at disparities and differences across other maternal sociodemographic characteristics, so more to come. While I love quantitative data, I think the qualitative data and personal testimonies are also really, really important to highlight. And so this quote comes from a mother from Denver Health who had 2 children, about 2.5 years apart, impacted by fetal opioid exposure. And so here she talks about her firstborn. With my son, I didn't even get to go down and see him for a couple days. With her, this is her most recent infant, I was able to engage from the start. This time, at least, my ability to breastfeed or give my milk isn't limited by anything like medications like last time. So even if I'm not doing it for longer than a couple minutes, when I do it throughout the day or it varies, at night, I try to get in as much skin to skin as I can for her comfort at sleep and my milk production. I'm glad that the ESC thing is in effect, where they're not having to administer morphine, but I know that if she needed to, they would have it all at the ready. And so it's a sort of the N of 1 trial, right? Where a mom who's the N of 1 has experienced 2 kids pre-post CHoSEN Quick. And so I'm going to pause my updates there and hand it over to Jaime Cabrera, who is the Executive Director of CPCQC.
Thanks, Susan. Good morning, everybody. As Susan mentioned, there's been a tremendous amount of work happening with this collaborative. And what I wanted to do is really reassure you that even in this uncertain time that we all face, not knowing what tomorrow holds, that we actually have seen increased amounts of funding from our partners, and that's nationally and locally. And so we at CPCQC, as partners with a number of other organizations, are able to provide some COVID resources. We're working with the CDPHE, Department of Health in our state, to put on a perinatal care webinar series that you all receive information about in the coming weeks, so that we can disseminate best practices, share information, and continue collaborative learning. We've heard from many of you from surveys, from other ways that we've had conversations and queried you, that during this time there's a lot of information, it can be overwhelming, and that most hospitals are practicing medicine differently. There's not a standard or a norm, and we know that outcomes can vary when best practices vary. And so we want to bring everybody together to continue to be a resource for you. We continue to do our quality improvement work that's underway with our cesarean reduction initiative, some of our antibiotic stewardships that are happening, and certainly this work with CHoSEN Quick. We have also received additional funding from the CDC to continue to expand and enhance the current opioid work. So in addition to the funding that we received through this September, there is another opportunity for us to apply this month and receive funding through next year as well. So we've been working with Susan and Jillian and Jade and a number of other folks on this call today to really dive in to say where are some elements of this program that we could actually implement some new interventions with you all that would be helpful, and get the funding for that. So more funding from the CDC. Also, we have partnered with Zoma Foundation to be the backbone organization of the Maternal Mental Health Collaborative and Framework, and are working with CDPHE on their maternal mortality prevention program to implement patient safety bundles to address our #1 reason for maternal mortality in the state. And we know that that is suicide and/or overdose. So a lot of the work that we're doing with some additional partners and additional funding actually has an overlap, as we know that substance use and psychiatric disorders often coexist. And so we'll continue to focus in these areas. But again, we are really encouraged that our national partners like the CDC and HRSA continue to provide funding for this work, which is very, very important, and will hopefully only bring more resources to bear for your work in your hospitals and your communities to increase the amount of resources that we can provide to pregnant and postpartum people, infants, and their families in this area. And we will actually be sharing more details about some of these opportunities that you can all participate in at the end of today's session, in additional funding with OBH partnerships and other local entities as well. So look forward to not only the work that's happening now, but additional resources in terms of readiness and education, response and screening, and being able to then coordinate care and activate a lot of the work that you all have been doing in these work groups. So continue the great work, and we'll continue to be here as a resource, and we'll continue to go after all the funding that we can get to really expand these efforts, as we know they have a tremendous impact, and we're seeing some really significant outcomes. So thank you all for being here today. And with that, I am going to pass it on to Jade from Illuminate, Colorado.
Hi, everyone. I am in the office today with a couple other folks. I'm going to be mostly masked, but I'll just do a couple of quick updates. So the Colorado CHoSEN Steering Committee continues to be meeting, and really there's so much happening in this space. Jamie just gave you a few highlights, but really the list just goes on and on with all of the work that's happening around prenatal substance exposure. So I'm going to kind of give some highlights about the different steering committee work groups for folks that aren't connected to those, and then I'll share more at the end around different things. So the CHoSEN Steering Committee has been working very closely with our Family Advisory Board around making sure that there's close alignment between the two. We've done some work on our mission statement, our vision statement, and an equity statement to make sure that we are fully addressing kind of all of those different components, and that really the steering committee and the Family Advisory Board have some shared perspective on that. Our data and research work group is working to not only continue to support the data linkage project that I think we've talked about in the past, but they're also developing a new qualitative research study, and that's going to be going in for IRB fairly quickly. The FASD work group, as you may know, put together a gap analysis and is now looking at doing a community roadshow, which was supposed to be in person and about halfway through now, but it's fully virtual these days, to receive feedback on that gap analysis findings and the recommendations that are contained therein. The plans of safe care work is continuing. The work group itself is supporting the dissemination of that. I believe many of the folks on here were part of the March 2nd Plans of Safe Care launch event. Might be the last time that many of us were in a large room with other people. How crazy is that? But so that is all moving forward. The implementation looks a little different these days, but the dissemination is continuing. Our policy work group is monitoring different opportunities based on our policy framework. I'll chat more about that in a second. And then our provider education work group is continuing to maintain and improve the toolkit that is up at chosencollaborative.org. So for my next slide, thank you, Susan. We have been working with the Sun Steering Committee on a draft landscape analysis. So I mentioned there's multiple different moving pieces that are connected here. And so we will share that with you all. I think that will go out in the follow-up. And just to really start to capture all of the different pieces that are moving related to this issue. In terms of in progress and implementation, some updates here. We've been working on a child care pilot project that has been, that is in the midst of implementation right now. We'll see what happens with that. That is really around making sure that we're increasing access to child care on site at substance use treatment facilities. And that's really focused on infant child care and increasing access to treatment for ideally mamas and babies together. Last year, some women's health and substance use disorder behavioral health co-location pilots were funded. Those are in progress. So those are the 228 pilots. You might have heard them. They were part of the Senate Bill 228. Those are in progress right now. One of the things we had talked about previously was a change in residential substance use disorder treatment and the Medicaid benefits, so how Medicaid pays for or can pay for residential substance use disorder treatment. That is requiring some federal changes and federal waivers. That is currently postponed. And then the maternal opioid misuse federal grant that was awarded to our healthcare policy and financing. That one is, that grant, the MOM grant, is also currently in implementation. So that's just a highlight of many of the things that continue to move. And then the Children's Code changes that we've been discussing for a while around how a child tests positive at birth and determinations of child maltreatment that follow. That is in Senate Bill 28, the recovery bill that may still have a path forward when the legislature reconvenes. Other than that, there are some pending federal funding applications for our state, both a SAMHSA grant that's been submitted through the Office of Behavioral Health, and then also a HRSA grant focused on FASD that we are working in partnership with Dr. Wells and the Kemp Center on. And that's all in addition to the wonderful things Jamie shared. So as you can tell, the list is long of how this work is just continuing to grow and be impactful. And we are so thankful to be in it with all of you. And I will share more at the end on how to get involved in any of these things. And then we'll also be sure to send follow-up emails with everything you might want to have access to.
Great, thanks so much, Jade.